So, without further ado, I am very, very excited to introduce Dr. Lisa Walke, who is the William Malmesey Truman G. Schnabel Jr., MD, Associate Professor of Geriatric Medicine and Gerontology, and our very own Chief of the Division of Geriatric Medicine for the Perelman School of Medicine at the University of Pennsylvania. In her role here, she's responsible for overseeing the day-to-day operations of the division, which is composed of 21 faculty members, 7 nurse practitioners, 4 clinical fellows, and 30 plus administrative, clinical, and research staff. Under her leadership, the division is improving the quality of care provided to older adults, advancing clinical research in Alzheimer's disease, health disparities, sleep disorders, and the interface between socioeconomic status and disability, and educating the next generation of healthcare professionals on fundamental geriatrics principles. Dr. Walke's research in implementation science focuses on innovative educational and care delivery models that improve health outcomes for older adults. She has a very extensive career, so I encourage all of you, if you're interested, to read her full bio on our website. But without further ado, I am going to turn it over to Dr. Walke and say thank you again for joining us today.
Good afternoon. So before I start, can you see the slides now, Allison? Okay, great.
Yeah.
Thank you all for joining. As was mentioned, I will plan to give some pauses along the way. I tried not to have overwhelming numbers of slides and have a little bit more detail so we could go a little bit more slowly and go through the information I want to present. Certainly, I believe, as Allison mentioned, these slides will be available online on the Penn Memory Center site. So if you don't quite get something or can't copy it down before I move to the next slide, you certainly will be able to go online and be able to get the slides there. So, but any and all questions are welcome, and Allison's going to man the chat for me, as it's sometimes hard to do both. Okay. All right. And so during this session, as I had mentioned with the information, we'll review medications that are commonly used to manage both behavioral and psychological symptoms, often experienced by persons who have dementia. And we're going to talk about difficulty sleep, depression, anxiety, and agitation. But before doing that, I thought it'd be amiss not to at least give an overview of the medications that we use to address and treat dementia. So starting on the topic overall, dementia, and just making sure we're on the same page, we know that both having problems with your memory and problems with your cognition or your function because of the memory problems you're experiencing. And this was an ad from one of the medications we're going to talk about, donepezil, a couple of years back. So when we look at both the oral and dermal, as I'm saying, or topical through the skin, medications that we use to slow the progression of Alzheimer's disease. None of these medications are indicated or proposed to improve memory or to reverse Alzheimer's disease. They're all intended to slow the progression of Alzheimer's disease, to have a longer period of time until decline is recognized, or slowing the decline. That said, they acknowledge that there will continue to be decline, it's just slowing it down. So with that in mind, I put down this slide both the medication, what the first name is the scientific or name, or the generic name, sometimes we'll call it, for the medication, and then what you see in parentheses is the brand name. Which are oftentimes easier to pronounce and sometimes more familiar with people. So donepezil or Aricept is the first medication of this class that was prescribed. There was an earlier one, Tacrin, that pretty much no one uses anymore because it caused liver toxicity. But donepezil was approved back in the 90s, so oftentimes people ask me, well, how long has this been out, or how much experience do we have with these medications? That's why I put down on this slide how long they've been out, so you can see. Typically, we'll start with 5 milligrams as the starting dose. Although there are times that if I've had someone who's either had sensitivity to one of the other medications in the past, or just if they're a smaller person, or you're maybe more concerned, maybe they have more GI, gastrointestinal problems, that we might start with even a lower dose of just doing a half of the 5 milligrams. but the maximal dose is 10 milligrams. This is a once-a-day medication. They did come out with an additional 23 milligram dose that hasn't been shown to have much additional slowing benefits than the 10. It has a little bit, but not that significant. So oftentimes you might stop at 10, although you can go up to 23 milligrams. With each dose increase, there is the potential of having side effects. And so sometimes you're okay with 5, but when they get to 10 milligrams, they'll experience some side effects. Rivastigmine is the next one, and that also has a patch formula called Exelon. Part of the reason why is that rivastigmine and all of these classes of medications can cause gastrointestinal side effects. So typically a little bit of nausea, maybe some queasiness, loose stools, diarrhea. Those are the most common. Urinary incontinence, so difficulty holding or controlling your urine. That's also a potential side effect from these medications. The side effects through the GI tract are lessened when you use the patch, because then you're absorbing the medication through your skin. And so that's why rivastigmine has the Exelon patch that is also a once a day, and that's what I'm showing you, the 4.6, 9.4, and then similarly they came out with an even higher dose of 13.3 that again hasn't been shown to have a lot of additional slowing, but does have some, versus the oral formulation, which is a twice a day medication. So you'll notice then that galantamine as well is also twice a day medication. They do have an extended release that can be taken once a day. And then all of these three, donepezil, rivastigmine, galantamine, are cholinesterase inhibitors, is the class that they're called. Memantine is an NMDA receptor antagonist. So what's the difference? It works on a different part of your brain in terms of trying to help slow the progression. So donepezil, rivastigmine, and galantamine can all be taken individually by themselves, or they can be taken along with memantine. Donepezil has been approved for mild, moderate, or severe dementia in terms of the severity, whereas rivastigmine and galantamine have mild and moderate. Memantine is specifically for moderate and severe. So if someone has mild dementia, at least from an FDA approval point, they wouldn't be on memantine per se. And when I say severity level, that had been measured in the initial studies with doing mini mental state exam, a score of 15 or lower. Those were the individuals that showed benefit on memantine. And then they came out Nanzaric, which is a combination of donepezil and memantine. So instead of having to taking 2 tablets, you can take 1 tablet that combines the 2 if you're on both of those medications. So the thought was to try to make it simpler instead of having taken multiple medications to take just that 1. So before I go on to Leqembi, are there any questions about these medications thus far? You're muted, Allison.
Nothing so far. Let's give it a second to see if anyone has a question they're typing.
I have a question, but I can't find the chat.
Okay, you can go ahead and ask it. Just don't share your name, okay?
Okay. Can you take those pills with the new lecanemab? I know we didn't get the lecanemab yet, but that's my question. Can you do both?
Good question.
Good question. Excuse me. It's so new with lecanemab that I haven't had anyone that's on both. I don't think we're typically doing both. We would be doing one or the other, but it's not an exclusion that you couldn't take lecanemab because of one of these medications. That's a good question. I don't know, Allison, do you know? I don't have anyone that's on both. I have people that are on one or the other.
Yeah, we're typically managing people on one or the other. But theoretically they could be on
Right,
both.
you could
Yeah.
be. It's not a contraindication, but we're using one or the other.
Okay, 2 other questions from the chat. One is, I was told Aricept does not slow progression. Is this true or is this untrue? It does slow progression, so some confusion about what exactly it does.
Okay, so Aricept is intended to slow the progression of decline. But there will still be decline. It doesn't stop, but the initial studies, when it got approval, they looked at time to nursing home placement as a measure of someone's cognitive and functional decline. And individuals who received donepezil took 12 months to have decline, where they saw like about 6 months of, it took about 6 months for the decline in people on placebo, or meaning you didn't have the medication. So it wasn't that it stopped it. It wasn't that they didn't eventually get there. It just took a longer period of time to get to that same level of decline where they needed additional assistance. So it has been shown to slow, but not stop.
Okay, thank you. Also, a lot of questions. I'm going to combine these into one that are basically asking, how effective are these medications really? Do they really help at all? Like, how can we manage our expectations around their effectiveness?
Yeah, that's a really good question. So, which is why I tried to start with, they're not intended to reverse memory problems or give you back memory or improve super memory. And so before, when I'm having discussion with any of my patients about and their families about these medications, you want to start with those expectations. This is not going to be super memory. You're not going to notice, for the most part, most people don't notice drastic differences. So people will come in and say it's not doing anything. And quite frankly, that's pretty much what we're expecting, because it's slowing a course, it's not improving. So are they miracle medications? No, absolutely not. Are they going to make huge amounts of difference? Not necessarily. But until we are in the era that we're in now, and then we'll go to Leqembi next, these were the best that we had in terms of slowing the progression of cognitive decline. So do you have to be on them? Absolutely not. But they are something that can help and help with the slowing. It could also be that your course, the person's course of dementia, might have been slow to begin with. You know, you can't really tell. And so I don't want to oversell to say that these medications are absolutes or that they have definitive improvements, but they do, but they have been shown to help and to help slow. And again, depending on whether or not that slowing is sufficient for any individual, and particularly when you start them, because it doesn't give you back. If you start at a later point, it's going to help you slow from that point on. And if you're already at a level that there's challenges, you really may not see as much of a benefit from it.
Thank you so much. All right, I'm going to take two more questions on donepezil and memantine. So
Okay.
one is, Dr. Walke, have you heard of someone being on 20 milligrams of memantine? And why would someone be put on a dose that high?
Yeah, so sorry, I should clarify. So when I'm showing you the 10 milligrams, BID means twice a day. Sorry, I should explain that.
Okay.
So BID is twice a day. So that would be a total of 20 for the course of the day. That would be the maximal dose of memantine. I did want to point out, I mentioned some of the side effects or concerns with the top three medications. Memantine is cleared by your kidneys. And so anyone who has kidney impairment, chronic kidney disease, or any impairment of their kidney function, their maximal dose per day for memantine should be 10 milligrams total for the day. But when I'm showing 10 BID, that BID may twice a day, so that's really 20 milligrams.
Great. Okay, one more about donepezil and memantine, and then the person who asked a question about anxiety, I think we're going to get to that further along at the end. So don't worry, I'm going to read that question just a little later. So this question says, my mother has been taking donepezil and memantine for, in capital letters, years. I am unfamiliar with Nemzaric. Is this something we should consider at this juncture or combine with the two pills? So what are the considerations there?
So the consideration with Nemzaric is if you're on 10 milligrams of donepezil, because Nemzaric only has 10 milligrams. So if someone were only taking 5 milligrams, you wouldn't necessarily consider Nemzaric unless you wanted to go up to that higher dose. But if they're on maximal dose donepezil and they're on any level of memantine, then yes, the Nemzaric could be a consideration to decrease pill burden. So there's a 7 milligram / 10 milligram. The 7 in the combination is the memantine, and the 10 is the donepezil. And so they have 7, 14, 21, 28. So whatever level of memantine, as long as they're on maximal dose donepezil, could be used. So if taking, 2 or 3 pills, if you're taking the memantine twice a day and then once a day for the Aricept is burdensome or difficult, and you'd rather have one pill that gave you the same dose of medication, then that would be an indication to consider something like Nemzarek.
Perfect. All right. I'm sorry, let me sneak in one more question. This is the
Okay.
last one, and then we'll move on.
Okay.
Are these drugs as effective, or are they commonly prescribed for FTD or frontotemporal degeneration in addition to Alzheimer's disease?
Yeah, so they're indicated for Alzheimer's. That's the FDA approval. That said, we often know sometimes we act like dementia is purebred, and it's not always that case, right? It's not always that someone only has Alzheimer's. You can, and it's quite common for people to have combinations of different types of dementia. So if there is a thought or indication that maybe someone had frontotemporal and perhaps there is a component of Alzheimer's, that might be the indication for using these medications to treat that Alzheimer's component of the presentation, as opposed to being strictly just frontotemporal. Their indication is not just for strict, if you think it's only frontotemporal to be using them, but oftentimes there is a combination. So we'll oftentimes try these medications to treat that additional Alzheimer's component.
Got it. Okay, thank you. Let's move on.
Oh, now does it want to move? Okay.
I'll
Okay.
find it.
CC now? Did it move? Yes?
Yep.
Okay. So lecanemab, and the brand name of lecanemab is Leqembi. It has been shown to slow cognitive and functional decline in persons who have early stage Alzheimer's disease. And I want to emphasize that it is not indicated for moderate or severe Alzheimer's disease. The indications are for early Alzheimer's disease or even like a mild cognitive impairment. So very early on. Patients with Alzheimer's disease have a buildup of a protein that we call beta amyloid in their brain. Oftentimes you may hear it called amyloid plaques. And so lecanemab is a synthesized human monoclonal antibody that targets beta amyloid. And studies have shown that lecanemab can reduce the buildup of beta amyloid, and it slows the decline in the person's ability to carry out day-to-day activities. So as I said, if someone has mild stage dementia or a mild cognitive impairment, they would be considered eligible for lecanemab. But it's not a tablet, and therefore the process is a lot more lengthy, and even the eligibility process is longer. So in order for us here at Penn, we are offering lecanemab, and the process that we go through to see if someone is eligible is you have to have first your history and has history and assessment to show that you had at least mild cognitive impairment or a mild dementia. Then you need to have an MRI of the brain. And the reason why we're doing that is we're looking for small bleeds called microhemorrhages that are common to have in the brain with people with Alzheimer's disease. But if you have those small hemorrhages, a lot of them, that may increase the risk of you developing side effects to lecanemab. We do blood work to determine if there are other causes that might be creating the cognitive impairment, and therefore want to address and treat those. Need to have genetic testing. So we're looking for the ApoE4 gene. Everyone has copies of these genes, but if you have one or two copies of the particular subtype E4, those individuals have a higher chance of getting side effects to lecanemab, and so we want to know that. And then we also want to have beta amyloid testing in the brain. So we want to see that you have higher levels of beta amyloid in the brain, because this medication works by lowering those levels. So if your level isn't high, there wouldn't be an indication for you to get one of these medications. And we check the beta amyloid level in your brain by either getting a PET scan, which I will say right now has been challenging for a lot of people to get, or get a lumbar puncture, so some spinal fluid. So a needle we put into your back and draw up some spinal fluid, and then we're able to check for beta amyloid that way. I forgot to mention ApoE4, we can check either in saliva or blood. But the beta amyloid is either a PET scan or a spinal fluid. So how do you get the medication? It's given by infusion every 2 weeks. And because the main potential side effect is getting small bleeds in your brain, which are called ARIA, amyloid-related imaging abnormalities, you have to have serial MRIs of the brain. So before the 5th, 7th, and 14th infusions to make sure that there's no swelling or any signs of ARIA. Also, if you develop any side effects like a headache or any indications that might be associated with ARIA, you would need to get another MRI at that point in time. Also, Medicare, patients who have Medicare for their insurance, they need to consent to having their data collected. That's part of Medicare's coverage with evidence development policy. So that's lecanemab kind of overall. Again, the other treatments were either by mouth or through the skin. Lecanemab is through IV. Do we have any quick burning questions about lecanemab, or I'll go on to the other symptoms and we can come back to it at the end?
There's a question, a few questions actually, about what is considered mild dementia. So some people are using different staging models here, but how are we determining what is considered mild, or whether someone would be eligible?
Yeah, so we're determining it through our cognitive assessment. So looking particularly at mini mental state exam score or score on the Montreal cognitive assessment. So we've established kind of cutoff levels. So around the score, I believe, is 24 for mini mental. Certainly, if you're that score or higher, that would be considered a mild stage dementia, as opposed to if you had a score in the teens or something that would indicate more of a moderate. So we're using at least these assessment tools as a general kind of break or determination of someone having mild or someone having more moderate impairment, because again, it's a cognitive assessment test, so it gives us some objective information rather than the subjective, well, they don't seem like they're that impaired. This way we have an objective score.
Great. Then one more, and I think we can move on. How are small bleeds unrelated to lecanemab differentiated by ARIA, or those caused by lecanemab?
So how are they determined just in general, do you think? Or I mean, if someone is on lecanemab?
It looks like the question is, if someone is on lecanemab, can we differentiate between ARIA and maybe small bleeds that they've already had? Let's see if this person is.
Okay. So if I'm understanding it correctly, part of the reason why we're doing the brain MRI before you even get the treatment is to see if there's any evidence of any of the small bleeds. So if there isn't any evidence then we do the repeat MRI after you've had some of the treatment, or because you have symptoms, then we're going to attribute it to lecanemab. So that's why it's really important to have that baseline or before treatment MRI, so that we can see what the brain looked like then. And then after you get the treatment, any brain bleeding that we're going to see that's consistent with ARIA, we're going to attribute to lecanemab.
Okay. And then there's a question about the new Eli Lilly drug. Will it have the same limitations as lecanemab? I'll just jump in and say, we don't know yet, TBD.
Yeah.
But as soon as we know, you'll know.
You will know. And I will say that while this is still IV, one of the other things that's on the kind of hike or the horizon is they're trying to see if they can get approval for lecanemab to be a sub-Q formulation, because right now with it being IV, that means you have to come into an IV infusion center. You have to come into the hospital, basically. Like you have to come into one of our outpatient infusion centers or such and get it infused through your vein, whereas sub-Q would be quicker, and obviously oral, someone takes it home. But yes, we don't know. Stay tuned for dementia and see what will happen there. Okay. So I want to talk about some of the symptoms, since that was what we were trying to do today. And I want to start off with overall kind of approach to how we go dealing with symptoms related to dementia or in particular. So you want to describe the problematic behavior. Is it agitation? Is it problems with sleep? And the reason why this is so key and important is that the treatment or what would be recommended is going to depend on what symptoms are present, or maybe the combination of symptoms. So that's what's really important. It's not just, oh, they're having this. What is it? Sleep? Is it agitation? Is it lack of interest? Is it lack of appetite? You really want to be as clear as possible about what the behavior is we're trying to treat. Then the I for DICE is to investigate the possible causes. Could there be other things going on? Maybe an infection? Is there uncontrolled pain? constipation, is it a side effect from a medication? So we want to then do some investigation. Our C is create a treatment plan, and that treatment plan should be both non-pharmacologic, so non-medication interventions, as well as medication interventions if necessary. And then E is you want to evaluate the outcome of the plan. So after you put something in place, does it work? And if something isn't working, my approach is always that we need to do some tweaking then. If you're taking a medication to improve your sleep and your sleep's not improved, either that medication needs to be adjusted, so maybe increased, or taken off and tried something else. But you want to always have that evaluation. Are we getting the outcome that we're hoping to achieve? And so there was a randomized trial. So a trial, we have some people that did it, some people who did it, and they looked at caregiver distress. And using this approach was able to help reduce caregiver stress. So a systematic approach of how we're talking about symptoms and how we're trying to address them. So with that in mind, behavioral and psychological symptoms. So very, very common in persons who have dementia. About 90% will have some of these symptoms at some point in time. And when I say behavioral and psychological symptoms, what am I talking about? Talking about mood disorders, sleep disturbances, changes with appetite, whether it's up or down, psychotic symptoms, so things like delusions, which is a fixed false belief. You think someone took your money or is coming into your house and there's no one coming in. Those things would be delusions, or hallucinations, which can be either visual, so they're seeing someone or seeing individuals who aren't there, or hearing things that aren't being said or expressed. Agitation or aggression, excessive verbal or physical motor activity, and so either talking a lot or physically kind of being aggressive, physically moving around a lot, moving, things like that. And then sexually inappropriate behavior. So these are what, when we're referring to behavioral and psychological symptoms, again, one of these is quite common in someone with dementia. So there are a variety of medications that we use to manage symptoms: antidepressants, antipsychotics, anxiolytics. Antidepressant, anti just means against. So against depression, against the psychotic features I just showed you on the prior slide. And anxiolytics is against anxiety. So things to help calm anxious mood. So persons living with dementia who experience delusions can be as high as 75%. Hallucinations can be up to 50%. Agitation or aggression can be up to 60%. So atypical antipsychotics are used very frequently, often off-label, although just recently we did get one to be approved for the management of agitation in individuals with dementia, but I will go through that in just a moment. So there was a meta-analysis, which means looking at a whole bunch of different trials, looked at over 15 trials in over 5,000 older adults with dementia. 87% of them had Alzheimer's disease. And they looked at these 4 antipsychotics: Abilify, olanzapine, quetiapine, and risperidone. And the odds of death was higher, about 54%, in people who were treated with the antipsychotic medication. So because of that, the FDA issued a black box warning in 2005 for the use of atypicals, and then they extended it to all antipsychotic medications in 2008. So with the exception of Brexapro, which was just, or Rexulti is the brand name, which was recently approved for agitation in older in individuals with dementia, all the other antipsychotics are still being used off-label, meaning that they aren't approved in that manner. So there was another review that looked at 17 clinical trials, over 5,000 patients, and they looked at people with several different types of dementia. I'm showing you the ones here. And then again, they looked at those 4 antipsychotics to see was one more effective than the other and what benefits we received. So basically, in terms of safety, there are safety concerns, pretty much from all of them. None of them were any more safe in terms of mortality compared to placebo, meaning not getting a medication. When you look at cerebrovascular events, so things like stroke or mini strokes, which we call TIAs, I'm showing you that olanzapine and risperidone had increased risk of having stroke or small strokes, and Abilify had the lower risk. But they did say to be used in caution, any of these medications, if you have low hypovolemia, meaning low volume, being dehydrated, cerebrovascular, so brain or heart disease, vascular dementia. Those are times you want to be particularly mindful because these were shown to increase those type of events. The extrapyramidal symptoms, so more kind of neurologic and agitation symptoms. Risperidone has showed the increased risk, but quetiapine had the lowest risk. So if you have someone that already has functional or more functional components like Lewy body dementia or Parkinson's disease, these atypical antipsychotics may be less, would be preferred less because they're more likely to increase those symptoms. And then somnolence or being sedated or being tired, they all have an increased risk of doing that. Quetiapine has the highest risk. We oftentimes try to use that then if someone is having problems with sleep, let's say, and use it in the evening because we know it tends to cause sedation. It is not a sleeping med, though I want to qualify. It is an antipsychotic, but it does have the highest sedation profile. Risperidone tends to have the lowest. So again, that might be a little bit safer for a daytime use. And then if you look at falls, fracture, or injury, Risperdal, quetiapine, and amiproxolol or Abilify had a lower risk than placebo. So some question about whether or not they actually may be safer than if we're using it with that outcome in mind. But Parkinsonian symptoms are quite common as a side effect for atypical antipsychotics. Not necessary, but is a potential side effect. And so those symptoms could be bradykinesia, which is slowing of one's movements, not moving as quickly. Tremor, which is, like an involuntary shaking or twitching. Rigidity, so increased muscle tone, which might make it more difficult to move around or ambulate. And then slow gait with a decrease in arm swing, which is a normal way of walking. You have a little bit slower of a gait. Akathisia, which is a restlessness, maybe having kind of jitter, the shaking your leg or your hands, not being able to be quite still. Dystonia, which is sustained muscle contraction. And then tardive dyskinesia, which is repeated involuntary movements, can be eye movements, it can be mouth movements, hands, things like that. These are all potential side effects of atypical antipsychotics. So in conclusion, looking at this overall review, there is a trade-off between effectiveness and safety. Oftentimes, it doesn't have to be, but that's very common, it's likely. And so we want to really consider antipsychotic medications when safety is a concern or when the person that has dementia is particularly distressed by their symptoms. That's when we'll look about using atypical antipsychotics. The one caveat, as I mentioned, is Rexulti or brexpiprazole is an antipsychotic, but it was recently approved for use in agitation with individuals with dementia. So all the other antipsychotics are used off-label, meaning they're not approved in that regard. The way that they work is all the same. So in theory, they are working similarly, but that one was able to show, in terms of a safety profile, that it's a safe medication that we can use for agitation in dementia. I was going to stop and pause here, but I know I've got quite a bit more, and I was looking at the time, Allison. So if there are any questions, I can take them now, or I can take them at the end and try to get through a few more symptoms.
Yeah, why don't we get through a few more symptoms, and then there's some general questions that I can give you at the end.
Okay. All right, so mood disorders. So persons with dementia who experience depressive symptoms, quite common, as I'm showing on this slide. And so what do I mean by that? They're both physical manifestations. It could be poor appetite, low energy, sleep changes, sleeping too much, not sleeping enough, or behavioral manifestations. So irritability, not wanting to interact or engage as much, so some more social isolation, feelings of sadness, and apathy is a lack of desire, not wanting to do things, so not being able to initiate or get started. So common in individuals with dementia. So there are a lot of medications that we use for mood disorders. And typical for older adults, we typically start with SSRIs, which are antidepressants, serotonin selective reuptake inhibitors. That's what I'm showing, just the class, but basically antidepressants are the overall typical first line that we'll use for both depression and anxiety, because they've been shown to be safe in older adults. So that's why you'll see that I have depression, agitation, those things. These are medications that we'll typically use. The first few that I'm showing you, as I said, are antidepressants. Methylphenidate or Ritalin is a stimulant. So it's usually if someone's a little bit more apathetic, really not doing anything, it tends to work pretty quickly in terms of the time course. Antidepressants can typically take about 6 to 8 weeks, whereas Ritalin as a stimulant will work in a couple of doses. And then mirtazapine is a tricyclic antidepressant. It tends to make people a little bit tired, also a little bit more hungry. So we'll use that again if those are additional symptoms, which is why going back to that initial slide of the DICE approach, you want to describe what are the behaviors we're trying to address, because based on that, we might choose one of these medications over a different one. And then buspirone is an anxiety medication, an anxiolytic. Unlike medications that you might be more familiar with that can have addictive properties, like Ativan or things like that are used, benzodiazepines that are used for anxiety. They are physically addictive over time and tend to have rebound symptoms, particularly in older adults. Maybe some mental cloudiness, not being as clear, still being groggy the following day. Buspirone doesn't cause that. And so buspirone is also a medication used for anxiety. So showing the various different doses and the different indications for these medications. So cognitive stimulation plus a cholinesterase inhibitor like donepezil, ribostigmine, or galantamine has also been shown to be effective for mood disorders. So cognitive stimulation, engaging in cognitive or brain tap exercises, word searches, crosswords, jigsaw puzzles, anything like that that cause some stimulation, that plus cholinesterase can also help with mood. Just in terms of some things that are a little bit less effective for older adults, so paroxetine and fluoxetine have not been shown to be as effective in older adults. So oftentimes people may have been on them for many years and they were working better when they were younger and not so much so when they get older. Whereas something like sertraline or Zoloft or citalopram or Celexa, those are typically more effective. So it might be that considering a change or a switch over to a different antidepressant if the one that you're using isn't working. There is a concern about higher risk of falls with antidepressants, in particular paroxetine, and certainly for any tricyclic antidepressants. And also just being mindful that almost all antidepressants, but definitely the SSRIs, the serotonin selective reuptake inhibitors, which are the first line usually for older adults, they in particular can cause your sodium level to drop low. And when sodium level is too low, you'll get cognitive effects, some confusion, not being as clear, things like that. So again, trade-offs and trying to monitor, but realizing if you already have a low sodium or a low salt level, you might want to use, if we needed to use an antidepressant, be something like mirtazapine, which is a little bit less likely to do it, but it's not zero, so you still would have to monitor. Okay, so these are mood disorders. Like I said, I'm going to keep going to get through a little bit more and then stop, and then we'll have some questions at the end just to make sure I can get through a couple more symptoms. So this is just an example. Mrs. R is a 75-year-old woman with Alzheimer's disease. She resides with her son and his family. On occasion, she'll stay awake basically for all day, followed by long periods of time being asleep. And so her son is trying to ask, well, what can we do to help regulate so she's consistently able to sleep at night? So an example that maybe, might sound similar, familiar to people. So persons who have dementia and problems with sleep, very, very common, could be 60 to 70%. Frequent daytime napping will make that worse. As I often say to people, no one sleeps 24 hours a day or 18 after you get out of your infancy. So if someone's spending long periods of time sleeping during the day, it's highly unlikely they're also going to sleep at night because they've gotten their rest for the day. Nighttime wakefulness is also common in persons with dementia. So either difficulty falling asleep or staying asleep. So they'll sleep, but they're back up kind of quickly. And then agitation in the late afternoon or evening, which before you'd hear more commonly people call it sundowning. We try to not necessarily use that term as much, but you get the concept that late afternoon, early evening, typically when it's starting to go from day to night, might be some more agitation or sleepiness at that period of time. So a large part of the reason is that circadian rhythms have been disrupted. That's our body's natural way of sleep-wake cycle. And so we want to try to help get it back on cycle as much as possible. We know that sleep disturbances are one of the main things that increase caregiver stress. It's also one of the primary reasons why oftentimes pursuit of a nursing home placement will be considered, because no one can go, weeks or days on end without getting sleep. And so insomnia or difficulty with sleep, I always consider that as something that's a major emergency that needs to be addressed as quickly as we can, even though they are hard, it is hard to correct. But what do we use for insomnia? So there are a class of different medications. Melatonin is actually a hormone that we all have in our body. It's produced by the pineal gland. And what can happen is as we get older, the amount of melatonin in our body can naturally decrease. So the melatonin supplements are an attempt to kind of reboost the amount of melatonin that's naturally in all of our bodies. Our bodies release melatonin around 9 p.m. in the evening to let us know it's time to go to sleep. So the recommendation is, if you're taking melatonin, to try to take it as close to that 9 o'clock time, so that again you're boosting what your body is already putting out. The other medications I'm showing, Rometolon or Rosarim, is a synthetic form of melatonin, basically, and so it's trying to give a similar response as melatonin, but at a higher effectiveness or a higher dosing of it. And you can see that's 8 milligrams at night. Mirtazapine, as I showed before, which is a tricyclic antidepressant, but tends to make you sleepy, so we'll use that for sleep at times. Trazodone we'll often use for sleep. It is an antidepressant, but not a very effective one at low doses. At lower doses, it just tends to make you more tired. So sometimes we'll use it for sleep in the evening, or if there's agitation during the course of the day, to try to take the edge off some of that agitation. Doxepin is a tricyclic antidepressant. The tricyclics tend to make you sleepy. This one is going to be one of the ones that we have, the tricyclics, in terms of cognition and safety. This is the safest of them, even though they can all cause sedation that prolongs to the next day. And then Suboxone is an oxygen receptor agonist. It's just recently shown to help with amyloid as well. So there's some thought that that one in particular may be beneficial in individuals with dementia, that maybe it might be helping a little bit with decreasing the amyloid burden, as well as helping with sleep. So that might be one to consider if sleep is an issue. Medications we want to avoid: antihistamines, benzodiazepines, and then the medications that try to mimic benzodiazepines, because these can cause gait instability, persistent mental cloudiness, and also physical addiction. The other thing I wanted to highlight on this slide is Benadryl or diphenhydramine. That's usually what's considered the PM in sleep medicines: Tylenol PM, Avo PM. You want to try to avoid those, because again, it can give those lingering effects. I won't go through the example in the interest of time, but basically it was given an example of an older man who's exhibiting some sexually inappropriate behavior. So what would we do for that? Sertraline and clomiprazine as antidepressants have been shown to be helpful. They can help decrease libido, reduce some of excessive obsessive behavior. We'll often use anti-androgen medications for men, obviously. So lowering the testosterone level, or if we need to, then if we don't get the oral progesterone effective, then leuprolide would be the alternative that we would use after that. But that's an injection. So we typically try one of the oral medications first. The first two can be used men or women. Progesterone obviously is for men, and then leuprolide is also for men. So to summarize, medication, anti-androgens are for sexually inappropriate behaviors. Antidepressants can be used for a variety of things: mood disorders, sleep, changes in appetite, psychotic symptoms, agitation or aggression, excessive verbal or physical motor activity, and sexually inappropriate behaviors. Antipsychotics can be used for sleep disturbances, psychotic symptoms like delusions or hallucinations, agitation or aggression, and then excessive verbal or physical motor activity. And then medications for anxiety can be used to treat mood disorders, but also that excessive verbal or physical motor activity. Cholinesterase inhibitors, the donepezil, galantamine, rivastigmine, can also be used to help with mood disorders if there's a depression part with that stimulation. So trying to help stimulate them a little bit more. And then MMDA antagonists, that's the memantine. There have been some studies to show it might help with the excessive verbal or extrapyramidal side effects. We don't often use it just for that, but if someone has that and has cognitive issues, that might be why we would go to that medication. And then pineal hormones, again, to simulate what your body normally does and to help with sleep. So to summarize, behavioral and psychological symptoms occur commonly in persons who have dementia. Non-pharmacological interventions are the first line. So this was a medication talk, but I do want to let people know first thing should be the non-pharmacologic interventions. There's often times where there might be a trade-off between safety and effectiveness. But our primary treatment goals are to enhance quality of life, to maximize function, and we want to do that by improving behavior, sleep, and mood. And before we go to questions, I just wanted to point out, because like I said, non-pharmacological interventions really should be first line. And this is a book that I've recommended to a lot of my caregivers, A Caregiver's Guide to Dementia, and it goes through how to use activities and other non-pharmacologic strategies to address the behavioral symptoms that are common that we just went through. And so at the end, in addition to give you example of activities, it'll go through specific symptoms, what to do with the agitation, what to do with insomnia, and how you can manage them in a non-medication view. And a lot of my caregivers have found this book to be really helpful. So to both explain why these things are happening and then how we can address it. So I wanted to mention it, even though this is a medication talk, I just wanted to share this with everyone. So, and on that, I'll end to hopefully have some time for questions. A few minutes.
Okay, I co-sign. That book is excellent. And I'll also add that if the person you're caring for is a patient at the Penn Memory Center, you can always contact a social worker and we'll do a little bit of brainstorming with you. Okay, so Lisa, there's two related questions. Is there a role for medical marijuana or CBD without cannabis? Well,
Right.
it sounds like they're asking CBD without the THC, without the psychoactive.
For behavioral symptoms or for pain? Do they say?
Or it says, this one says for sleep/behavioral issues.
Okay. I haven't myself recommended or have patients that use it with my guidance, let's say, for behavioral agitation. Of the two, I would say CBD, so that you don't have the cannabis, the known cognitive impact. I've had patients use them for more like CBD oil and things like that. It will help with pain. And I've had people swear by that it really is beneficial. So I would say of the two, you could certainly try, but I would be concerned about trying actual marijuana because that would likely have the cognitive effects. And with someone that's already having cognitive issues, I don't think that would be a good combination. But CBD, if you try it and that seems to be beneficial, that's not going to have the same detrimental effects. So I don't personally have experience with it, but I wouldn't say that it couldn't be tried.
Great, thank you. What are extrapyramidal symptoms?
Yeah,
I think you might have mentioned that earlier. And
I did, and then I tried to go through it, but it might have been a little bit too quickly. So extrapyramidal symptoms are potentially side effects of some of the antipsychotic medications, and so it can be tremor, it can be agitation, it could be tardive dyskinesia. So it's the pyramidal system is what controls those. So these are extra symptoms that you get, a little bit more agitation in those areas. So that's what the extrapyramidal side effects are.
Thanks for reviewing that.
Mm-hmm.
All right. Any other questions? Please put them in the chat. Let's give it a minute for folks to type. I'm just going to scroll up and make sure I didn't miss one. Okay, well, no more questions so far, but lots of praise for you, Dr. Walke. You're a wonderful source of information. So helpful in explaining, really useful info. Thank you. Lots of thank yous. Is sertraline bad for cognition?
Not that has been shown in any particular study. If I mean, I always say everyone's an individual, right? So if for you or for your loved one, if they're taking sertraline that's causing problems, then that might not be a good medication for them. I will say sertraline is one of my go-to, like in terms of if there are problems with mood, and I haven't seen that it's caused cognitive problems. If anything, it helps alleviate or improve mood, and therefore then I can really do an assessment of if there are cognitive issues, what's the true cognitive issue versus the depression or the mood component on top of that. So I haven't seen it causing cognitive problems. If anything, I've used it to help clarify, to help make it more clear to me what part of it has been mood and what part has been cognition when I'm trying to address both.
And then let's take one more question. I want to be mindful of time. So, what about, yes, everyone, you will get the slides. Yes.
Yes, and I apologize because I'm like, I might have talked a little bit too quickly, so I knew everyone would get the slides, but I did want to get through at least all of the symptoms, so I apologize.
Yeah. So, some folks are asking about apathy, and are there any medication treatments that you use for apathy? Sorry, some with apathy, some agitation with apathy, but apathy.
Apathy is definitely a challenging one in terms to get people a little bit more stimulated. What I have seen to be the most effective, and I did mention it on one of the slides, is methylphenidate, or Ritalin is the brand name for that. And so typically we'll use it as a bridge until, let's say, if there's depression is the underlying, we might use it as a bridge until those 6 to 8 weeks and the antidepressant has kicked in. Or sometimes we'll just have someone on Ritalin and just keep them on that if that's stimulating and working enough. Because it is a stimulant, the caveat is if you have certain cardiac or certain heart conditions like atrial fibrillation or things like that, that would be you wouldn't be eligible for a Ritalin, because since it is a stimulant, it would more likely trigger that if you already are prone to having atrial fibrillation or have it. But if you don't have any cardiac arrhythmias or any cardiac issues that would be concerning, I have seen Ritalin work really, really well. And like I said, within a day or two. So it's not this long-term effect of just getting the person to be willing to engage more and interact and do activities. Because it is a stimulant, you also have to take it during the day. So you either do it at 6 a.m. and 12 p.m. or 7 a.m. and 1 p.m. Because if you take it too late, then it'll impact someone's sleep because it can be that stimulating. That's what I've seen to be most effective. Antidepressants can work as well, if again, depending on the severity. But if you're getting to the point of being apathetic, usually an antidepressant may not be quite enough, but certainly can be used as well. So I would say that's been my experience of what's been most effective. But that said, apathy is a challenging symptom to address.
Lisa, I want to be mindful of your time. Do you need to go, or do you have time for another question or two?
I have time for another question or two. We start a few minutes after 12 as well. So.
Okay. A question about side effects of risperidone. Does risperidone cause drooling?
It can for some people. So yes, it's not that, again, none of the side effects are true for everybody, but and some things that are lower prevalent for some people are not so low, right? So you can see some increase in risperidone. Again, it's not one of the common side effects, but I have seen it, and you can get that. So it may be, again, as I mentioned on one of the slides, the trade-offs. Like if risperidone is otherwise working for whatever behavior it was started for, but the side effect is the increased drooling, that might be the, the kind of weighing is the increase in drooling so bothersome or worse than the benefits you were getting from the behavior it was that it's treating. If it's not working to treat the behavior and you're getting the drooling, by all means, you need to come off of it and try something else.
Okay, thank you. And let's do one more. Can polypharmacy cause dementia-like symptoms?
Can polypharmacy, so the definition of polypharmacy is taking multiple medications, over 4 or 5 medications. So just in and of itself, there would be a lot of people that would have dementia if it was just polypharmacy. Now, what combination of medications you're taking can cause cognitive issues. So if you're taking medications that are either interacting, or that multiple medications that have effects on brain, then yes, that can cause, or even like I mentioned, Benadryl. As I said to you, you want to avoid the PM medications because it can cause mental cloudiness, right, or confusion. So, and that doesn't have to be, polypharmacy doesn't have to be a lot. It could just be that one medication. So certainly we know that individual medications, I mentioned benzodiazepines, things like Benadryl. There are medications that have effects on your brain and can cause you to be less clear and can cause you to be confused. So not just polypharmacy, just certain meds, yes, can cause confusion.
Okay. Someone had their hand raised. I don't know if that person was having a hard time using
Yeah,
chat.
She answered my question.
Oh, she did. Okay, good.
Yes.
All right.
There's another hand now, Allison. Will?
Yeah. Okay, go ahead, Will, if you want to. Oh, Will, I'll answer your question. If it's the last question you asked, I can answer it in the chat.
No, it's just about the my mom was on Depakote at one point for agitation, and she developed ataxia, and so it was discontinued. I just want to know, is that how often is Depakote used for agitation? I did not, you didn't cover that at all. So
Yeah, so good question. So Depakote used to be used a lot for agitation. I used it a lot for agitation when people, particularly if they were aggressive, hitting, or just like agitated. We were using Depakote for the mood stabilizing effect. I will say I personally thought it worked pretty well for a lot of people. But maybe about 8 years ago, a study was done and they looked and according to the study, Depakote was no more effective than placebo or no medication for helping with agitation and could potentially cause side effects. So around that time, it kind of started to fall out of favor of us using Depakote as we were using it before to help with agitation symptoms. So once it was shown that it wasn't really as effective as it subjectively seemed to be when we were using it. So I would say if I had given this talk 8 or 10 years ago, Depakote would have been on the list and would have been high on the list of something to use to treat for aggression or agitated behavior. But now we haven't been using it quite as much, again, based on the results of that more recent study.
All right. So I want to say one more time, thank you so much, Dr. Walke, for your expertise. You're getting a lot of thank yous, and this has been great in the chat, so I want to pass that on to you. Again, yes, we will email out the slides, and the recording will probably be available within a week or two. If you're registered for this event, you will get an email from me when it's available. Our next Empowering Caregivers session is on April 19th at noon with Patricia Quigley of Laurel Hill Funeral Home, who's going to be talking about advanced planning for end-of-life and funeral care. She was recently named Funeral Director of the Year, so we're very excited to have her. So Lisa, thank you again, and thank you everyone who was able to come today, and we'll see you next month.
Thank you.
Bye.